Hello, everyone, and welcome. We're so glad you're joining us today because we're really excited about this webinar. All of our team is, I definitely am. We're going to talk about how we actually talk and communicate about health equity. So my name is Karen Bell, and I'm an Associate Director of Partners for Advancing Health Equity, which is a national learning collaborative based at the Tulane University School of Public Health and Tropical Medicine, and funded by a grant from the Robert Wood Johnson Foundation. So Tulane is here in New Orleans. So we first want to acknowledge that the land that we're standing on here is known as Balbancha, a Choctaw word meaning a place of other languages. And we honor generations past and present of the several tribes who live in this region. So, like we said, this is a collaborative. We are about connecting. We're about getting to know one another, And I think a great way for us to do that is for people to drop in the chat where you're joining us from and maybe a little bit about the weather. So, like I said, we're here in New Orleans. It's hot, but that's to be expected in July. So just let us know where you're joining us from. I see somebody from Chicago, another NOLA person, DC. Hi, I was just in the DMV area. Yes, hot NOLA. That is an understatement. Idaho, hello. Philadelphia, hello. Did I miss Philadelphia again? Okay, so we have some Philly connections. Richmond, Atlanta, Texas, yes. Kansas, New Orleans is hot. Hot, but not as hot as it was in June, yes. As we discussed in this health equity collaborative, climate change is real. And we know that we, as well as other people across the globe, are experiencing the effects of that with this heat. So keeping all those people in mind, South Bend, hello. Augusta, Georgia, hello. Atlanta, Durham, I am a North Carolina native, so hi. And welcome to everyone, another New Orleanian. Hi. So we, again, like I said, are so glad to have you here. And like we said, again, this is a place where we connect with each other. At P4HE, which is our nickname for this collaborative, Partners for Advancing Health Equity, we know that we must go beyond simply documenting health inequities because we already know they exist, right? They've been documented for more than 100 years, and many of us experience the injustices that are the roots of health inequities. P4HE, yikes, I'm again very excited about this webinar, so excuse any flubs, but P4HE aims to bring people and organizations together to work across sectors to better understand important issues related to attaining health equity. One of the ways we do this is by providing spaces like our regular webinars for deep conversations on important health equity topics with the aim of promoting actionable solutions. Some of the main questions we're asking here at P4HE are, what do people envision when they think of health equity? And more importantly, how do we get there? You can view recordings of our previous cross-sector discussions online. Today, we're happy to discuss a topic that we think is critical to our goals, changing how we talk and communicate about health equity in order to actually achieve health equity. We're going to break it down today. I'm, again, so excited. You can join the conversation on social media by using the hashtag partners4HE. We've also set up a mural board. If you're not familiar with using a mural board, the link is in the chat for doing that. It's a way for us to discuss these topics that we are going to talk about today, particularly how we're talking and who we're talking to. So you can share your thoughts there throughout the conversation. You can also, as always on Zoom, share what you want to share or ask questions in the chat. So back in April, we held an interactive session, also using Mural, where we discussed how we define health equity. About a month after that, a study was published that found that when white participants were exposed to news articles that highlighted racial inequities in COVID outcomes, the participants' fear of COVID was reduced, and so was their empathy for those vulnerable to COVID. The study also found that support for COVID prevention and safety precautions went down among white participants who were exposed to data on the higher rates of COVID in Black and Latinx and some indigenous populations. So the results of this study might make you ask, okay, what do people really think about health inequities and this idea of health equity? It also makes you think about how we as a society communicate about health inequities and what underlying beliefs people have about health equity. I think about, for example, how we recently declared racism as a public health crisis. We've done the same with gun violence. But what does that really mean? And what do people in our country, from elected officials to even your own family members, think about that? We talk a lot about the social determinants of health, and there's lots of research, as we all know, on health and education, health and housing, health and discrimination, health and healthcare access, basically all of the social determinants of health. But what are we really talking about when we say that health equity is when everyone has the fair and just opportunity to be as healthy as possible? How do we communicate about health equity to make sure that we understand not only what it is, but how we actually achieve it? So let's start that conversation today. First, by asking about where you receive information about health and health-related issues. So again, we want to have these conversations back and forth. There's a poll that should be coming up soon, and you can answer this question. From what sources do you receive information or communications about health and health-related topics? So go ahead and let us know what you think. From what sources do you receive information or communications about health and health-related issues? All right, so I don't want to say who's in the lead, but it looks like newspaper, in print or online, okay? Local news, cable news is relatively low, and we can talk about that with one of our panelists who is at CNN. Social media, which we are not shocked that that is high up there. Also podcasts, which is my jam, and public radio. Okay, so that is a wide array, right, of sources for this information. And this is interesting. Again, we're going to talk a lot about this in a few minutes. The next question is another poll. Do you talk to your family and friends about health equity? You can answer this one now too. Do you talk to your family and friends about health equity? I'm really interested in this topic or this question as well. All right, so the majority say yes, and some small percentage say no, or a smaller percentage say no, which, I think we understand there are reasons for why people might not be able to or willing to talk to, their family or friends about health equity, particularly for the things that we mentioned, that is really about injustices that people experience. And sometimes that can be difficult to talk to your family or friends depending on the context or the relationships that you have. Understandable. Okay, so that got us thinking about some of these issues related to communicating about health equity. Today's panel includes journalists, podcasters, and researchers who all have expertise in communicating about health equity. So I'm gonna have them introduce themselves because they all are extremely accomplished. They all do a lot of different things, and it's just easier for them to introduce themselves. So just everyone, while I'll ask each one to introduce themselves, they can say what they do, as well as maybe give their own definition of health equity and how it impacts their work. So let's start with Nicholas St. Fleur.
Hi there. Thank you so much for having me. I'm really excited to be here. So I'm Nick St. Fleur. I am a science journalist over at STAT, which is a health and biopharma publication. I also host a podcast on health equity there called Color Code, and I also help manage some of our live journalism as well. So to me, health equity is about understanding our past as a country and the impact that that has had on where we are today, on where healthcare is today, these discrepancies we see between life expectancy, between getting diagnosed for certain diseases and such, and how deeply rooted that is in the history of our country, and the impacts that race and the impacts that racism has had on the different outcomes we see in our healthcare system. So thank you so much.
Yeah, thank you. Thank you for that introduction. And like I said, I'm very excited for this panel. And next, we'll have Bob Ortega. Just introduce yourself and maybe what you define health equity as.
Sure. Hi, thanks. I'm Bob Ortega. And by the way, let me start by saying thank you so much for inviting me here today. I'm really delighted to be joining all of you. So I am a senior writer and investigative reporter at CNN, and I'm also the chair of the advisory board for the USC Center for Health Journalism. And it's really in that capacity that I'm speaking here today. The USC Center for Health Journalism has a number of programs, all focused on health equity, that work with journalists. There's a national fellowship, data fellowships, and then California fellowships, for all of which this is a very important component. And I think, I completely agree with the definition that you put up and what Nicholas was just saying. I also think that for us, really thinking about health equity means thinking about the big picture, right? We tend to think about health issues in terms of healthcare. Often we tend to think about, maybe to some degree public health. We don't necessarily think about the broader infrastructure that affects our health on a daily basis due to where we live. And that could be anything from access to water, access to healthy food, access to, how we're impacted by policing. I mean, there's just a myriad of areas that we're talking about there. So we try to look at the broadest possible picture when we talk about health equity. Thanks.
Okay, thank you. And I hear, actually, I don't know if other people hear, but I hear some connections between what you said, Bob, and what you said, Nick, that is huge. These are huge problems, and they're also historic and systemic that are affecting us in our current context. So thanks. Next is Duane Reynolds.
Thank you so much. I am equally as happy to be a part of today's panel session. My name is Duane Reynolds, and I am a partner with the Chartis group, and I am the president of Chartis Just Health Collective, which is our health equity and belonging consulting and educational firm. I've spent over 20 years in healthcare administration. That is my background. I have my master's in healthcare administration, and a good majority of my career was spent inside of provider organizations, particularly academic medical centers, helping them do anything from strategy to operational turnarounds. And through the course of that 20-year career, I have really defined a space for health equity within the field of healthcare administration, and really helped to raise these issues to the leadership level, which oftentimes has a lot of impact on the decisions and the resources and the strategy that organizations ultimately decide. So I consider my target audience really those who are in positions of power within health plans, hospitals, health systems, medical groups, public health agencies. And in terms of what I really view health equity as, it's really about looking at the systems, institutions, and individual manifestations of bias and racism that play out inside of organizations that ultimately are creating these obstacles to people achieving optimal health. And of course, as we look in the community itself, we also understand that social and environmental determinants of health and political determinants of health also impact one's ability to achieve optimal health. My focus today is mainly on helping organizations through that transformation process of understanding how to look at the decisions they make from an equity-grounded framework.
Okay. All right, thank you. I appreciated you breaking that down for several reasons. One, because now I understand what you do, but also I think the students that I have are MPH students and they're learning about health equity and they're like, okay, well, what do I do with this? And your career trajectory was a clear example of how you can be equity focused in these fields that our next generations are coming in. And then also giving really that cross sector, we have 2 journalists that we started off with, and then someone in healthcare administration. And next we have a fellow researcher like me, an academic, Lillie Williamson.
Good afternoon, everyone. I also am super excited to be a part of this panel and for the conversation we're going to have today. I am Lillie Williamson. I am an assistant professor at the University of Wisconsin-Madison in the Department of Communication Arts. I'm a health communication scholar. I think a lot about the ways in which particularly racial experiences and racism interact with health communication and what that means for racial health inequalities and inequities. As part of that work, I think about the impact of things like vicarious racism. So what happens when you read a news story about racism and the impact that might have on perceptions of health and in particular medical mistrust. My sort of view on health equity aligns very much with everyone else. I guess I have the benefit of having gone last. So I'll think about sort of what I can add. I think for me as a communication scholar, I also think a lot about the language that is used and what it means to speak about equity as opposed to disparities, which in the US we like to use disparities or inequalities and sometimes disparities and inequalities interchangeably and sort of shy and don't use inequities. And that has a very specific meaning. It means that there aren't just differences. They're not just avoidable, but they're also unjust, which signals that there are other things that we should be doing about it and thinking about the ways in which it sits within these structures. Because in my work and in my sort of perspective, I also think about this as being embedded in these systems and institutions. And, I always tell my students that really all policy winds up being health policy. All of these things impact the ways in which we live and grow. So I'll leave it there.
Well, thank you. Really appreciate, again, all of you all being here. I'm ready to get started. But before I do, everybody watching, attending, again, I just want to remind you that you can drop questions in the chat, but also you can use the mural board. The link is also in the chat for that. And really it's a way to get your thoughts out as well as connect with other people and hear what other people are saying. So feel free to do that while the panelists are talking. Actually, I think I want to start off or build off of something you said, Lillie, about the difference between disparities and inequities. And I want to ask Nick and Bob about sort of that concept. Really, I want to ask, as journalists, how do you consider the differences in how people think about health equity or health or disparities or inequities or whichever? How do you think about that when you're doing your work?
Nick, do you want to go first?
Certainly. Thank you, Bob. And thank you for that question. And Lillie, thank you for that insight as well. As someone who has probably used those words interchangeably as well, it definitely gives me some food for thought in terms of how I approach those topics and making sure that I'm using the correct terminology for what I mean. So I like that. I like when I can come into a panel and really come away with some things that, oh, I should change that about myself, or I should really think more on it. So yeah, in terms of to your question, Karen, a bit about just how I approach health equity in my stories, who I kind of think my audiences, what those messages are and such. I would say as a journalist, I look for stories that have that human aspect to them. I have a podcast, I have readers as well. One thing that connects with readers, that connects with listeners, is hearing that human element, that narrative, someone who is going through this, or heaven forbid, the family members of someone who passed away from an incident or from a victim of something having to deal with health disparities. So in terms of stories I've covered through my podcast Color Code, we've tried to tackle the Black maternal mortality epidemic we have in this country by interviewing the loved ones of a woman who passed away following giving birth. And just hearing about the impacts that has had for them. And then we take that story and we expand upon it to talk to researchers about what this epidemic is, talk about the numbers, talk about how Black women and Black birthing people are 3 to 4 times more likely to die during childbirth. And we put that context in there. So I think giving people a human as opposed to just the numbers, you start off with like that human story and then you expand it, is one way to really reach folks through our work, through our medium. But also one thing I've noticed is that not everyone, always responds to health equity in that way. In some cases, you do have to talk about the business for health equity, the business case, which unfortunately, I personally feel like, why should I have to make the business case for this field? But there are folks who are looking at it and say to themselves, like, okay, like, what does this mean in terms of cost savings and such? So I definitely would encourage people to also, do some research into the business case for tackling these health disparities. If you're looking to reach people who unfortunately aren't swayed by the human narrative that drives so many of these stories.
Go ahead, Bob. Sorry.
No, that's fine. Thanks. I thought that I want to build off something that Nicholas was just saying, because I think it also, I was very struck, Karen, at the beginning of this when you said we all kind of know what health equity is. And yet I think a lot of our readers and listeners and viewers don't. They don't have a clue. And a lot of journalists don't either still. People who are listening to a panel like this probably maybe more than most. But, and I think this also speaks to the issue that Nicholas brought up, which is, for example, when we talk about things like this, one of the things that popped into my head when you were speaking, Nicholas, was a couple of years ago, I did a whole series of stories about prison healthcare in Arizona, which is terrible. The prisons in Arizona are absolutely horrendous, and the prison healthcare is horrible. And I was struck by how many times I would talk to people, including state legislators, who would say things like, well, why would anybody in prison complain? They get 3 squares a day and they have healthcare provided to them free. Now, mind you, it's not any meal you would ever want to eat, and it's not healthcare you would ever want to receive. But there is this I think, perception on the part of a lot of people that blocks them from seeing this in a way that maybe we would like them to understand it. So when I think about these issues, I think about both how we get journalists, reporters, and editors to think about health equity and to think about it holistically, and then how we and they can help our readers and viewers and listeners understand those inequities in the health of our communities. So at the Center for Health Journalism, for example, a big focus has been to help to look at how to help journalists who come through our program to think about the health of communities, to think about the effect of things like trauma in early childhood and how that trauma can have an effect on an individual's health throughout their lives, and therefore why programs that help, say, build resilience in individuals and communities and how we cultivate that are important, and then to help their audiences understand that because that's important too. I'm talking about, like, to give you an idea of some of the things I'm talking about, we've had recent projects from some of our fellows have talked about things like how a Florida sheriff's office used predictive policing algorithms to target youths that they believed might commit crimes. And that led them to conduct incredibly aggressive surveillance against these youths and their families, effectively pushing families out of their communities. Or another project on how the impacts of the COVID pandemic on the Navajo Nation were exacerbated by longstanding issues with drinking water access, poor transportation, and road systems. Another project looked at how changing nutrition regulations to require folate enrichment in masa, that is corn flour, could help to address nutritional deficiencies leading to birth defects among among children born to migrant farm working families that tended to rely on corn masa rather than wheat flour in their diets, right? And I think that speaks to the kind of issues that often don't occur to people. If you think about, for example, the notion of enriching wheat flour because everybody eats bread. It's basically an assumption that everybody eats bread, which is not necessarily true when you look at different communities, right? One of the project, a very good one 2 years ago, looked at how a community garden project in Milwaukee provided a venue for mentoring and saving young men in an area with one of the highest incarceration rates in the country for Black men and one of the shortest life expectancies. So, in these and a lot of other projects, I think the work is to reach out beyond our immediate usual audience and try to communicate with people in communities who may not normally be reading or watching or listening to our news outlets, to try to figure out how to engage them in our work and in causing change. And that also means often working in partnership with community organizations and NGOs. And that can be a challenge because journalists often think of their role as one in which we're not supposed to be advocates, right? But I think we have to go beyond just, and you mentioned this too, Karen, it's going beyond just pointing out the problem to looking at how we address that and try to come to some solution.
Yeah. Thank you both for that. That was a lot to process. But one of the things that I heard, I'm actually connecting the dots between one of our previous webinars where we did talk about maternal mortality and pregnancy-related mortality. And we had, again, a cross-sector panel. And one of the things that sort of came out was this idea, or not really idea, this need, like Nick said, to humanize the issue, to tell people's stories. And I actually kind of want to ask a follow-up, but directed to Duane in one area and then Lillie in another area. So follow me. Okay. So this idea of humanizing, and then Nick also mentioned sort of like the business case of health equity or health inequities. Duane, you interact with healthcare organizations. How do you balance humanizing versus business case versus maybe even structural? Lillie, I'm going to ask you about the structural stuff, but how does that work for you when you are talking about this concept of health equity?
Thanks for that question. There is a balance, but I think it always starts with the story of humans, of patients, of community members, right? Of which we all are a part of in some way, shape, or form. And so when I go into organizations and I'm meeting with executive teams, part of creating the business imperative and helping them understand why this work is so important and relevant to the work that they do is first establishing their why. So I get them discussing, where we are in our society today, our understanding of systemic racism and how it continues to have a stronghold, and how it, was once much more overt acts of racism have become covert. And after the murder of George Floyd, we all had this moment of understanding in a different way. And so what I ask of them is, what is your responsibility and to whom? And I ask them oftentimes, take out a picture of your child and think about the conversation that you would have with your child or your grandchild around what you did at this opportune time to actually make a difference. Did you shy away from it, right? Did you pretend like it wasn't there? Because that's what we've always done, and that's why we are where we are at today. And so connecting to that humanistic part of who they are becomes so relevant to get their commitment to change, because no one wants to leave a world behind for their children and their children's children that is anywhere resemblant to what we have today, now that we acknowledge the impact of systemic racism. Of course, there are folks that need to understand the business case, right? And I existed in that world, making business decisions, financial decisions about where to place clinics, about access and things of that nature. Oftentimes, there's a disconnect between their understanding of those business concepts and health equity. And so I connect the dots in a very real way, in talking about things like access, and talking about the Medicaid population in particular. Many organizations struggle with Medicaid as a payer because they pay so poorly. And so they create strategies around how to gather the sources of revenue, perhaps how to limit access for Medicaid patients. And, I have to point that out as a way of actually contributing to the problem, right? If you're limiting access for a group of patients, they're looking at it from a payer perspective, but I want them to look at it from a human perspective and understanding that if we're actually going to move towards value-based care and population health, and we're achieving health equity for all, then we really have to be not thinking about it in a way that is business-like, but in a way that is humanistic, right? But then we also have to help them understand that there are going to be trade-offs here, right? They have a limited pot of resources within which to use to make health better or to advance health care. And so part of the business discussion is about helping them refocus their energy and their efforts and their resources towards solving this health equity issue that actually causes them lots of costs and quality issues and safety issues on the back end. So I've got to get them to understand that today's decisions about resources really are going to impact your financial viability as we think about a world in which value-based care and population health is paramount.
Yeah, I think that argument makes a lot of sense to me. It also makes me think again about, climate change and the disasters that we're seeing everywhere, but right now is happening in Europe. Those discussions of, hey, we have to help the most vulnerable and make these changes now because the costs later are too great. Yes, I appreciate that that perspective and you spelling that out like that. And again, I know that might not have been what you were expecting to talk about. So I apologize if that's how you feel. But I want to ask Lillie something sort of on the other end, but similar about, so Duane used the term systemic racism, right? And so people use systemic racism, structural racism. We also have structural sexism. I've seen a couple of papers that talk about structural transphobia or homophobia. Like, as a communication scholar, how do you think about these terms that might focus on structures, these sort of distal things that people can't really put their finger on, and then linking that back to the humanistic, the storytelling, the putting a picture to people's lives that we've been talking about? How do you think about that as a communication scholar?
Thank you for that question. It's hard, and it's hard to tease apart because the ways in which we know the structures are having an impact are from the interpersonal interaction that you have with a physician or a policymaker. They often come out of those interpersonal interactions, but they're because of these larger policies and issues. So disentangling them in a lot of ways doesn't make sense, and in some ways isn't as helpful. And so I think it's really about using those narratives and thinking about the stories that we use to humanize issues and linking those to, this isn't just about a single individual. There's actually sort of a structure at play. There are policies, there are institutions. And because of that, this is why you're seeing that. And it really is a balance. I don't know, as Bob was saying, similarly to, not everyone really has necessarily the same grasp or understanding of health equity. I think that also applies to when we think about what structural and systemic and institutional racism is and looks like. And so there's really a balance in terms of, we want to point to the structures, because if you only use the stories, then you run the risk of it being, in communication, we think of it as episodic. It's a single episode, it's this individual. Those sort of things can sort of make group cues and stereotypes salient. And we, particularly in the US, we assume that behavior is individualistic, that everything comes down to people's choices, not the fact that people's choices are constrained and impacted by all these systems. And so making that link, I think, can help help those stories that we want to help sort of create empathy and sort of bring the human element, but also linking that to the structural issues. And in doing so, we have to think about, I'm trying to think, maybe Duane was talking about this, but thinking of them sort of as part of the community, because a lot of times when we are talking about these things, part of it is an issue of outgroups. It's particularly when we're thinking about like policy support, like that doesn't apply to me, though this is about those people, quote unquote. It's an outgroup issue. And so if we can reframe how we think about community and thinking about the context of the COVID-19 pandemic, we're all linked, we're all in community together, but that's not how the populace necessarily thinks about community. So I'm thinking about the social science and medicine piece that Karen mentioned. As a communication scholar, I wasn't surprised. I was having conversations with my communication and health inequalities class in fall of 2020 about that it was unlikely to be coincidental that everyone got really tired of stay-at-home orders and we saw people storming state capitals soon after there was all the discussion of which communities were being heavily impacted. Dr. Bigman conducted a study that came out in 2014 that talked about when you talk about things comparatively, it makes the group that statistically is less at risk think they're at even lower risk. And so when you're hearing, oh, this is impacting Black, Indigenous, and Latinx communities, you have a huge portion of the population that then says, oh, well, that's not me. That's not part of my community. So I also think that part of it, as we're thinking about empathy and humanness, is also trying to sort of reconfigure and re-envision how we talk about and think about community.
If I could just jump in real quickly there. Now, I'm no expert at all when it comes to monkeypox, but with what you just said, Lillie, I feel like we're seeing the exact same thing with monkeypox right now.
Yeah, and I'd like to just add to that. I was struck, Karen, by the research that you mentioned at the top of the conversation around perceptions and of white people when they read about health inequity and whether or not they take action around it. And to your point, Lillie, I think we have to reframe this discussion because the reality is health equity isn't just about Black people. It's not just about Latino people. It's not just about the LGBTQ community. It is about all of us, right? At any juncture, health equity can be an issue that affects populations differently. And so in order to solve for it, we all have to be a part of the discussion, particularly white people, because white people have the center of power in this country. And so they have to be a part of solving the problem, albeit leading from behind, right? Allowing people who have had lived experience in populations that are disproportionately impacted to be at the front of the table, to be speaking about our experiences and advocating for change in certain areas. But we all are part of health equity when we talk about it. And if we lead from that perspective, then, perhaps we can engage others in the change process that's necessary to create optimal health for all of us.
And if I can just maybe say one quick thing to add on to that, which goes back to what Nicholas was saying too, which is this is where I think the really kind of working to talk about this through the stories of individuals and really bringing those individuals to light makes a huge difference. Because, if you look at the abortion debate right now, for example, right, and the issues that are going on, and this 10-year-old girl who had to, flee Indiana to get an abortion, wherever you fall on that debate, it's hard to imagine anybody saying, well, the hell with that 10-year-old girl, right? I mean, that's why telling an individual's, we're not only getting a very limited picture, obviously, but the point is, when you see the impact on an individual, it's very different than when you see the impact, when you just are, kind of thinking about the impact in the abstract.
Thank you. I think we actually have a question from the mural that aligns with what we're talking about. So I guess I can just ask it to everybody, but maybe I want us to transition into podcast too, because I listen to podcasts all the time, but so that's sort of a selfish thing. But the question is, when you are interviewing individuals for their personal stories, I think we just heard a lot of examples of this. What practices do you employ to mitigate re-traumatization when they're discussing their experiences? So what practices do you employ when you're interviewing people about their personal stories to mitigate re-traumatizing?
I'll jump in on that. Honestly, listening, giving them the time to just share with you their stories. You can't be too quick to interject, to double, to fact check everything that they're saying in that moment. Listen. With my podcast, Color Code, so often we deal with issues of patients who have experienced racism during their medical visits and such. And oftentimes, when the way we approach racism in the medical field is if a patient feels an interaction or something was racist, we listen to them, we believe them, we give them the opportunity to share that experience. We don't necessarily go back to the hospital, go to that specific doctor and say, hey, such and such patient said this interaction you had with them was racist. Was it really racist? We listen to the patients. You have to be careful not to gaslight your sources, the patients who are sharing these very intimate, very vulnerable moments with you. And sometimes gaslighting looks like, are you sure that was racism? But maybe they meant this, maybe, are you sure? Because just that feeling, and so many of us, so many of us Black folks, so many of us people of color, we know that feeling when something's just not right. And you think, wow, is that happening because of the color of my skin? So I would say in terms of not re-traumatizing people, listen, believe them, listen to their stories. Also ask them, hey, be very transparent. I have a podcast, I do articles, I say, hey, the words that you're using, they will appear in the podcast, they will appear in the story. I want to make sure you're comfortable with what you were saying. I bring up an example of a story I did looking at colorectal cancer and the rise of colorectal cancer in adults, in young adults, under the age of 50. In this particular case, I was looking at it, hot spots of death across the country where men were more likely to die at a younger age from colorectal cancer. And I put a particular focus on young Black men. And I spoke with this woman about her husband, a guy named Omar Carter. And she was telling me about, the symptoms that he was going through and his hesitancies to see a doctor, but also the graphic details about when he would use the restroom, and have bleeding from his rectum and what that was like. And she was very descriptive. She compared it to like, menstruation. She compared it to in some cases like a horror show. And I asked her and I said, the words you're using are very graphic, and I want to make sure you are comfortable sharing something so visceral with our audience here through this story. I asked her once she said it, we fact checked again. I asked again for permission. Are you sure you want, these quotes in the story? Because it is, your late husband, and it is something that is so, as I said, visceral. And she said, yes, people need to know what the signs of this are, but also they need to know how graphic this disease can be, especially when it comes to colorectal cancer, because that's one of the telltale signs that you need to go to a doctor. You need to get this checked out, and the earlier you get this checked out, the better. So in terms of re-traumatizing your sources, they're telling you their stories. These were traumatic moments, but you need to be there as a journalist, as a human listening. You need to show empathy, and you need to go back to them and verify with them, am I okay? Is it okay for us to share this story as you told it to me? So that would be my response to that question.
Yeah, I agree basically with all of that. I mean, I think that one of the things that has constantly surprised me as a journalist is how keen people are to share their stories. I've had to cover mass shootings on a couple of occasions, and that has included, unfortunately, talking to people who were, say, high school students, present when this happened. And, I think that the keys there are things like, one, accepting no. When someone says no, then that's no. The other thing is giving them the option to change their mind and back out. I have, this builds on what Nicholas was saying, which is most of the people that we're talking to in these contexts don't have experience in dealing with journalists. they're not familiar with things like what does it mean to be on the record or off the record or for background or, whatever, right? That's not in their universe. So I think it's really important for us as journalists to bend over backwards, to make sure that people understand the impact that this could have, being on the podcast, being on the being on CNN, being in a newspaper, whatever it may be. And so being very clear about that, and then B, if they then have the option to back out, and that can include days and even weeks later when you're continuing to work on the story, up to the last second. I check back with sources and let them know when the story's coming on. I don't necessarily tell them every single detail about everything that the story is going to be about, but I double check quotes with them and I go back with them, and if someone says I've been thinking about this and I really am not comfortable, then that's fine.
And thank you for that, Bob. I think that certainly makes a difference in sort of building respect and trust for individuals who have been traumatized. My podcast is called Centering Health Equity, and it takes a slightly different approach in that we are talking to practitioners in the field who are trying to do the good work of change and reducing health disparities and reducing health inequity. And so I would say the angle that becomes really important for our guest is really being able to tell the truth, right? To talk about some of the real examples of racism and bias that occur inside of healthcare organizations, to create the narrative, the truth narrative that our hospitals, health systems, other types of healthcare organizations are not devoid of structural racism, and that it is going to take us telling the truth in order to acknowledge and fix a problem that exists. Because oftentimes, healthcare organizations are characterized as being there for the community and advancing community health, which is all true. But there's also sort of a dark side of the history of hospitals in our country that has perpetuated injustices. There's a dark side of clinical research that has perpetuated injustices, and so I find it really insightful and comforting when we have guests who are willing, in some instances, to speak the truth and could face reprimand within organizations. But I think we're at that point where many people are comfortable enough to ultimately take on whatever is going to come as a consequence of speaking out about injustices. But that has to be a paramount part of how we fix some of these challenges.
Yeah, thank you.
I'm clearly not a journalist, but I want to circle back to something Nick said, because I think it's important for academics and researchers in talking about, Nick, you were talking about when talking to individuals, believing them and not questioning them. And if you think about, as scholars and researchers, we like to, use the existing names for scales and items, but like the idea that it's perceived racism and like using that, we have to be careful about the language that we're using in these spaces, because that has implications for how we are thinking about it, how we influence how others are thinking about it. And so saying that something was perceived racism essentially does the same thing Nick was doing, that it leaves open that, well, maybe if someone had been there, it wouldn't have really been a racist incident. And so we have to be careful and be mindful of those sorts of things on the sort of academic end of things as well.
That's so real. Sorry, in moderating, you try to keep it to the panelists, but that is very real. It also highlights again how we don't always connect people's real lives to what they are, what we're studying. And so actually, one of the things that we talked about in the prep meeting was misinformation. We have about 10 minutes left. So we're going to do it. We're going to talk about it somehow. because the podcasts are about, or I believe we've had podcast episodes about misinformation, at least from what I understand. And then Lillie, your research looks at vicarious racism and misinformation. So maybe we'll start off with you, Lillie, and then come back to the journalist side, podcast side, to maybe give a few quick points about that.
Sure. So as an academic, the unsatisfying answer is we need more research. But I do think that there are a ton of connections, and I think that it's becoming increasingly important because you have some entities who are at a point where they will try to essentially leverage communities' mistrust for anti-vaccination efforts, for instance. And so part of the problem is things that are misinformation or disinformation sometimes align with historical incidents. Like, it's not far-fetched to think that, that a hospital might be experimenting. We know historically that between US Public Health Service, studying of syphilis, forced sterilizations, there's been a long history of things. And so when you think about that history and then you see misinformation, it could resonate because it's not necessarily that far-fetched. And so thinking about what those connections are and where interventions are, I think is important. And along those lines, for me, thinking about language, the idea that the goal is to, because a lot of my work is in the context of medical mistrust, the idea that we should reduce medical mistrust, that language often coincides with discourse around like, oh, don't communities know how far we've come? Like, US Public Health Service study was so long ago, we've come so far. I think that in some ways that language can put the onus back on communities instead of rectifying the issues with the systems and structures that actually precede the mistrust. And so thinking about how do we help people sort of integrate that into their decision-making is one thing. Like, yes, there might be some risk because of this context, but here are also reasons why I might still engage in what we health scholars think of as quote unquote positive health behaviors. And so there are a ton of connections that as a scholar, I'm starting to try to disentangle and figure out what quote unquote intervention, even though I dislike that term in this context, but where do we intercede? How do we help people sort of hold that, but not sort of fall into some of these now essentially traps that are being laid based upon underlying medical mistrust beliefs?
May I add something there quickly, which is, I think there's also a significant distinction between misinformation, where somebody's merely got the wrong idea about something, and intentional disinformation, which we're seeing a lot of now, and some significant, very organized intentional disinformation campaigns, especially right now in the Spanish media, too, in Spanish language media, on a variety of questions, including the COVID pandemic, monkeypox, and the abortion issue. And so, I think that there's an additional role there in looking at the motivations and attacking directly the motivations of the sources of that disinformation in a different way. Because I think a certain amount of mistrust is a healthy skepticism is important, right? I don't, if my doctor tells me that I've got to take some pill or some medicine, I, always look at the label to make sure that there's no contraindications or anything like that. It's not that I think he's, incompetent, but I'm just double checking for myself because I'm a journalist. That's what I do, right? But for the average person to be skeptical about some of the things that they're hearing is not a bad thing, but we have to be careful to try to figure out how we can inform them in cases in which that slides over into believing disinformation that can lead them to be actively harmed. I'm being a bit general here, but I think there is that distinction worth making.
Anyone else want to comment on misinformation?
Sure, I'll jump in real briefly, and I'll bring it to yes, there's a lot of misinformation and disinformation dealing with COVID. There is misinformation and disinformation dealing with, a lot of things in our healthcare system as well. And if I could bring it back to that kind of colorectal story that I did there, what we did as a secondary story there was I actually went and got my own colonoscopy to show my readers, this is what the process looks like. And I was very, very surprised in kind of how people's views on a colonoscopy are, and how some distrust is there. People saying things like, hey, I don't want to be, passed out while a doctor is doing something with that part of my body. And a lot of this is, some of it could be like, kind of ha-ha kind of jokes, but some of it is really steeped in, medical distrust. So what we did was we showed myself getting a colonoscopy due to a family history of colorectal cancer. My mother had it when she was 34, which put me at higher risk, and meant that I had to get one early as well. So we filmed it, and we showed our readers exactly what the process is to help overcome some of the stigmas that's attached with this disease that is killing us. And a lot of this was spurred because of the death of Chadwick Boseman, a hero of mine, the Black Panther. So sometimes dispelling misinformation, dispelling disinformation means getting right in there and doing it yourself, or showing that first person view as you can, as it applies to that story. So that's something that we have done as well.
I would just add that, Nick, I think that that's what a lot of people want. So I did some focus groups, it's a while back now, but in Chicago, African Americans talking about organ donation. And part of the thing was, we want to see the stories. I don't want to see the stories of just the recipient. Like, what would it mean for me to be a donor? What does that actually look like? Like, I need the narrative of what it would actually look like for me to do this. Yes, I distrust it. I heard everything from, and that's part of why I started doing this work, because they were connecting it to police violence. They were connecting it to immigration policies. All of these things were fueling their mistrust beliefs around organ donation. And when asked, okay, what would encourage you? What messages, what would you like to see? It was, I need to see the stories, and I need to see what it would look like for a donor. So I think that aligns and suggests to me that that's really what people want and need.
Thank you for that. And I mean, when I was reporting the story, I was speaking to experts in this area. One guy even said, he was at a barbershop. They were talking about, the not even a colonoscopy, just the stool test, Cologuard, where you send your poop through the mail to people. And there's an SNL stint on this, but one guy said, I don't trust the box. I don't trust a company with my poop, which is saying a lot about the level of distrust that people have. And in many cases, it's very warranted. So the message I would also want to leave people with is, when it comes to distrust, we need to have a medical system that earns people's trust. And that's really where we need to put a lot of our focus and a lot of our efforts into. We need to create this system that people don't distrust. And part of that has to deal with reckoning with our past and, acknowledging it and making the proper steps and, dare I say it, reparations to move forward and address those past misgivings, those past misdeeds. Thank you.
Nick, I'm so glad that you brought that up. A lot of the work that we do inside of organizations is also identifying what the history of their community is and getting them prepared for truth and reconciliation, to really hit the reset button and earn trust again, because there are very real events that are carried down generation after generation around the history, and all with the intent of keeping people safe. But until we face that truth and reconciliation process, then why would people trust you?
Yeah, I just want to say I really appreciate this conversation. I think some key words that I'm taking back with me are truth, transparency, respect, and just really respecting people's human experiences. So with that, I thank everybody. Please mark your calendars for our next webinar, which is on Tuesday, August 16th. And we're going to be talking about structural violence, gun violence, and health equity. Stay connected with us through all of those things that you see on our screen. And again, thank you so much to our panelists. We really appreciate this. I learned a lot. I know everybody else learned a lot. So thank you so much, everyone. Bye-bye.